You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 22nd, 2025. Our topic is drug allergy. This is presented by Dr. Anna Wolfson, an assistant professor of medicine at Harvard Medical School, quality and safety director, and is the assistant clinical director at Massachusetts General Hospital in Allergy.
Some disclosures. I've been consultants for a few companies. So the outline for today, we're going to discuss adverse drug reactions and hypersensitivity reactions in general, different types of drug reactions, specifically focus in on the evaluation and management of drug allergy, and then spend some time on beta-lactam allergy specifically and what the recommendations are for that. So at the end of the talk, the participant will be able to differentiate between types of adverse drug reactions and hypersensitivity reactions, perform a careful drug allergy history, evaluate and manage drug allergy, including drug allergy skin testing, patch testing versus direct challenge or desensitization, and then understand how to manage beta-lactam allergy using specific guidelines and data. So I always like to start this talk with the concept of adverse drug reactions in general. It's a little bit dry to think about, but it really is important to think about the difference between a type A, which are predictable reactions, versus type B, unpredictable reactions. So even though we're allergists, we are going to see people coming in and asking us about type A predictable reactions, which really accounts for 80% of all adverse drug reactions. So this is really related to the known pharmacological properties of the drug. So this would be, for example, we know that if you take too much Tylenol, you overdose on it, you're going to have hepatic necrosis. But on the other hand, more subtly would be side effects. And so an example would be tinnitus with aspirin, or secondary effects. So for example, itch with opioids. And then of course, drug interactions, thinking through, Coumadin and antibiotics and the dosing that needs to happen there. And even though you think I'm an allergist, I shouldn't be hearing about side effects and secondary effects, every single day someone is going to ask you about this. So it is something to really think about and remain familiar with the side effects of the different drugs. This is where we spend most of our time thinking about the research and understanding how it impacts patients is type B, unpredictable reactions. And this is unrelated to the pharmacological action of the drug. Another way of thinking about it is that only susceptible individuals are going to experience this. The problem is we don't know who is necessarily susceptible without actually having them experience the event. Sometimes it can be a drug intolerance, and so that would be more like, some patients have, nausea and vomiting, for example, but it also can be non-allergic reactions and immune manifestations, so for example, drug-induced liver injury. And then what we really spend a lot of time and energy on is hypersensitivity reactions, or AKA drug allergy, and this is about 10% of adverse drug reactions overall. So a minority of situations, but something we spend a lot of time on. And so what are some risk factors for hypersensitivity reactions? I said some hosts are more susceptible than others. We don't always know, but there's certainly certain properties of the drug that make it more likely to cause a hypersensitivity reaction. And this is, for example, like it's less likely to be allergic to acetaminophen than to ibuprofen, for example, and that's related to the chemical properties of the medication. We do know that the dose, different strengths of medications, larger doses can be more allergenic. The route, IV, is more likely than PO to cause a reaction. The duration of treatment. This is something that's actually very important when thinking about the history, thinking about the fact that early on in the course of the antibiotic is maybe going to be certain types of reactions versus later on in the course would be other types of reactions. Repetitive exposure, and then concurrent illnesses. So the really famous ones, everyone's heard about the fact that HIV patients who take trimethoprim, sulfamethoxazole are more likely to have rashes. And then the other one that's super famous is Epstein-Barr virus plus amoxicillin. Rash can be as much as 100% of patients, so very, very common. And then thinking through the host, so age is a factor of the different presentations, which we're going to discuss. gender, more likely in females. A to P is a risk factor for drug reactions, prior reaction history. And then I said we don't always know about the host, but we are kind of understanding the genetics of drug allergy more and more. So here are a few specific HLA associations. Again, we're really in our infancy of understanding this and not quite ready for mainstream, testing everyone's HLA type before we start them on drugs. But hopefully more to come with research in the future. So I would be remiss to not discuss Jelen-Coombs classification. I always say the best part about being an allergist is that type 4 hypersensitivity reactions have 4 different subtypes if you're an allergist. So again, kind of dry topic, but it really does help kind of frame your approach to drug allergy when you think about your Jelen-Coombs classification. I also find it a really great way to speak to other physicians about what's happening. Even if it's been years since they've thought about Jelen-Coombs classification, it is something we all really learned in medical school and is sort of hardwired into people's brains. And when you tell them this is not a type 1 hypersensitivity, a lot of people really do understand, what you mean when you say that. So just to, remind everyone, type 1 hypersensitivity is IgE mediated. So this is mast cells are activated and patients will experience classic, what we call allergic symptoms. So it could be even allergic rhinitis or as severe as systemic anaphylaxis, hives, wheezing, angioedema. That's our wheelhouse. That's where we're comfortable. Type 2 hypersensitivity, this is IgG mediated, and this is going to be more like the activation based on the cell specific antigens. And so the example would be hemolytic anemia, thrombocytopenia, those types of situations where the cells are being directly affected. And then type 3 hypersensitivity, this is a soluble IgG antigen in which the complexes form in the blood, and the example there is serum sickness, and basically serum sickness is the classic example. Now I was saying earlier there's multiple different types of type 4 hypersensitivity, and we have to think through the different manifestations. So the first one is a Th1 cell mediated, so they're all T cells, but the first type of type 4A is Th1 mediated, and the example there would be like a contact dermatitis. Whereas we have Th2 activation, this is an eosinophil mediated, so that's like chronic asthma, chronic allergic rhinitis, or a maculopapular rash with eosinophils. If you have a perforin or granzyme B cell-associated antigen with direct T cell stimulation, this is more like the macular and bullous exanthema or hepatitis. And then type 4D is going to be neutrophil mediated, and that's, for example, AGEP, which we're going to be discussing during this talk. So just thinking a little bit more about a more detailed approach to Jelen-Coombs classification. I mentioned earlier the importance of timing, and this is super important when taking a good drug allergy history. This is a really useful way of thinking through the different types of drug allergy reactions that can occur. And what this table is really showing you is that if a patient presents, on day 1 with a rash, you're over here on the left-hand side of the figure, and you really are in the differential diagnosis of these things. So you're going to say, early on in the course, it's much less likely to be, for example, DRESS, which is drug reaction with eosinophilia and systemic symptoms. That's going to be later on. And so, yes, there is the concept that if you've been exposed to the drug before, you're more likely to have a sooner onset of some of these types of drug reactions. But the point stands that someone presenting on day 1 or 2 with a rash, you might want to think about a different list of possibilities than if it's week 4, week 5. So once someone comes in, they've been on a drug, it's been multiple weeks, you're over here in this category where you're thinking about, are we experiencing DRESS? Are we experiencing Stevens-Johnson's? Is it, what exactly are we dealing with? And you want to think about check their kidneys and their liver and so on, make sure you're not missing organ injury as well. So I really like that figure when you're thinking through the differential diagnosis of drug reactions. And there's so many different signs and symptoms that we can see with our patients. And again, thinking through the differential diagnosis for the skin involvement, if it's immediate reactions, we're going to have hives, swelling, itching. You could have some rhinitis and conjunctivitis. Whereas a more delayed rash is going to be morbilliform, maculopapular. You could have target lesions, pustular, exfoliative, or bullous. Again, more immediate, you're going to have, if cardiovascular involvement would be hypotension and tachycardia, and respiratory involvement with the IgE-mediated presentation, cough, dyspnea, wheezing. Confusion would be if the hypotension is more severe. And hematologic and end organ involvement, thinking about your eosinophilia, your drug-induced liver disease. Sudden GI symptoms alone, so just having diarrhea, for example, or nausea, that's more of a side effect and not a drug allergy. But certainly someone who's having, for example, concomitant diarrhea and hypotension and wheeze, that would be more concerning for an IgE-mediated anaphylaxis. So now that we kind of have some ways of thinking through the different possibilities, let's talk about specific examples of types of drug reactions. So again, our immediate IgE-mediated reactions are going to manifest with urticaria, which, as we all know, is erythematous raised pruritic lesions. I always say to my patients, do they look like mosquito bites? But they really should be lasting for less than 24 hours. You could have angioedema, often of the lips or the eyes, and bronchospasm as well. Delayed hypersensitivity reaction, so by far the most common, is morbilliform drug eruption, or MDE. This is a benign exanthem, a benign rash, and is so common, and we're going to talk quite a bit about it. We have the category of severe cutaneous adverse reactions, or SCARs, and so when you're speaking to people about drug allergy, they will often say, that was a SCAR, and they mean this category of reactions. This includes acute generalized exanthematous pustulosis, which is AGEP, drug reaction with eosinophilia and systemic symptoms, which is DRESS, Stevens-Johnson's, and TEN. There are other examples of delayed hypersensitivity reactions, such as fixed drug eruption, generalized bullous fixed drug eruption, serum sickness and serum sickness-like reactions, and then non-cutaneous organ-specific reactions, which I'm not going to discuss in a lot of detail today. I did want to just mention that our thinking about serum sickness being a strict contraindication to reintroduction of antibiotics has really changed in the past couple of years, and now it's not a strict contraindication, but more of a risk-benefit analysis with the patient. And more data is being published on that topic every month. So let's think about morbilliform drug rashes. So this is, again, a type 4 hypersensitivity, and it's going to manifest with a maculopapular rash. Generally, the onset is days into therapy. There might be a mild peripheral blood eosinophilia. These rashes can be distressing to patients, but they are generally benign and self-limited. If in the appropriate setting in which the drug is really needed without good alternatives, one can treat through. The biggest issue is that if you've ever seen a patient with a morbilliform drug rash, it is itchy, it's uncomfortable. Patients are not generally happy to have this rash. And so if there are alternatives, often patients will prefer to change. The really confusing thing about maculopapular rashes is that they may not recur on subsequent exposure. And so I do tell my patients that if they need this drug again, especially after the passage of a little bit of time, they are absolutely a candidate for taking it again. This is not a lifelong allergy for patients. And cross-reactivity is of less concern. What I mean by that is someone who has this type of a rash from amoxicillin, I really would, without any hesitation, give them obviously a cephalosporin, but even a first or generation second cephalosporin, and not be concerned about them having a severe reaction. So that at least gives you a little bit of next steps for these patients. So one of the examples of a scar that we mentioned earlier is dress. And I've talked about this a few times during this talk already, but it's definitely something that we as allergists need to recognize because it does have a high mortality. And the treatment is basically recognizing the condition and then withdrawing the culprit agent. And this is a situation in which one is advised to avoid rechallenge generally for the rest of their life. The clinical criteria is based on a series of different symptoms, including an absolute eosinophil count of greater than 1,500, the presence of a rash and systemic involvement such as fever, lymphadenopathy, hepatitis, and nephritis. I really generally you can use various scoring systems. I like to use the Regiscar, and in this day and age, you can Google Regiscar dress, and up comes a calculator where you simply input the information about your patient, what their eosinophil count is, whether they have a rash, if they have lymphadenopathy, those types of things, and it tells you the Regiscar score, including the likelihood that it is dress. So that you kind of know whether you should be concerned. The biggest problem with dress is look at this long list of culprits, which can be as a very common one is anticonvulsants, antibiotics, sulfasalazine, NSAIDs, ACE inhibitors, beta blockers, dapsone, allopurinol, azathioprine, diltiazem, methimazole, and dobutamine. All have been implicated in dress. And so the toughest part is the patients who are sick, hospitalized, and they develop dress. They usually have a med list, 10 drugs long at the minimum. And then as allergists, we're really sorting through, again, thinking about that timing table, what the likely culprits are, what they've been on for months is very unlikely to cause stress. So thinking about that timing and the combination of the likelihood and when the symptoms began, really trying to put together the most likely drugs, because avoiding rechallenge for the rest of their life is a big deal, especially if we get the wrong culprit. So moving on, another example of a scar is acute generalized exanthamatous pustulosis, AGEP. This can be infectious, so it's not always drug-induced. The presentation is with these multiple small sterile pustules on a background of erythematous skin. Patients will have fever and leukocytosis as well as neutrophilia. And there is, again, an AGEP validation score. The diagnosis is based on a clinical diagnosis, but PATH can be done as well. And the treatment is, again, recognizing the presentation of AGEP, stopping the causative drug, and providing supportive care and avoiding rechallenge. This is uncomfortable for patients, but not nearly as uncomfortable and dangerous as Stevens-Johnson's and toxic epidermal necrolysis. So this is, again, an example of a scar. The mortality is between 5 and 40%. Again, the differential diagnosis does include infectious causes. The presentation is with erythematous macules and atypical target lesions that can progress to necrosis and detachment of the epidermis. Score 10 is the scoring system which can be used to assess the prognosis. Mucous membranes are generally involved in patients. So when taking the history, I have noticed one of the classic questions that people asked in order to try to diagnose Stevens-Johnson syndrome is often the question of, were your mucous membranes involved? And the reason is because patients will often say that their skin, what they mean to say is their skin flaked, and they can make it seem as though their skin was almost debriding after having had blisters. With maculopapular rashes, patients' skin will absolutely be flaky afterwards, and it can feel like they're actually sort of, losing their top layer of their skin, they'll say. But with Stevens-Johnson's, it's not flakiness, it's blistering and peeling of the skin away. And so I really try to get, as much detail as I possibly can about what exactly the rash looked like and how it presented. The diagnosis can be clinical. You can as well do pathology, and the treatment is prompt recognition and withdrawal of the culprit drug. Patients can be treated in the burn unit, and we avoid rechallenge. And there's more and more evidence for trying to use alternative medications as opposed to steroids in Stevens-Johnson's for management of this condition. So I wanted to spend a minute on the concept of multiple drug intolerance syndrome. As allergists, we see these patients all the time, and this is differentiated from multiple drug allergy label and multiple drug hypersensitivity syndrome. The difference is that for MDIS, the patients have intolerances to, so basically adverse effects to 3 or more unrelated drugs. Multiple drug allergy, which is also called multiple drug allergy syndrome, is where they have reported but unconfirmed hypersensitivity to 2 or more drugs. And then MDHS is where the hypersensitivity is actually confirmed. And the thing is that most patients with multiple drug allergy labels have an intolerance manifestation. And so I really think it's important to think about these patients because it really impacts their medical care to have a very long list of drug reactions in their medical record, and doing what we can to try to delabel and enable them to have access to drugs really can actually change their lives. And so the recommendation is to do drug challenges, which are often placebo-controlled. When one does a placebo-controlled trial, how it works is you have the patient come in, and generally it's multiple visits, and one of the visits will be placebo only. So for example, it would be, cherry yogurt. And then you have them come in on a subsequent day and eat cherry yogurt mixed with the drug. And you're looking to see if they have sort of the non-immunological symptoms related to the placebo exposure the same way they do related to actually ingesting the drug. And then you can kind of explain to them that, you know, their anxiety, a lot of them do have untreated, unrecognized anxiety, is really affecting the way they're kind of processing their exposure to medical treatments, and hopefully enable them to have more options for treatment going forward. So now we're going to think about the evaluation and management of drug allergy. And again, when we're thinking about the history, you really do want to ascertain a lot of different aspects to try to bucket your patient correctly so that you can evaluate them in the appropriate way, diagnose them in the appropriate way based on what their history of drug reaction was. So the first most important question, I would say, is the approximate date of the reaction. This is important because patients who have had reactions more than 5 years ago, we know that due to the natural history of drug allergy, many patients will outgrow their drug reactions. And if their reaction occurred certainly years ago, but especially decades ago, then you really are in a good place to enable them to have exposure to the drug through drug challenge or re-exposure that we're going to discuss. You also want to have clarity on especially like what drug it was that they had the reaction to, if you can get the dose and the route, those are important things as well. The details, so how many days into the course was it? Again, that kind of gets at that same image I keep talking about, the differential diagnosis. If it was the first day of the course versus the 14th day, that changes your differential diagnosis of the likely type of reaction they experienced. Were there co-administered drugs? So, for example, a patient who has perioperative anaphylaxis, you're going to think about all of the different anesthesia medications. Yes, we do know antibiotics are a very common cause of perioperative anaphylaxis, but it's possible that it was one of the other drugs. So just making sure that you're not anchoring on one possible explanation. We already talked about the fact that Epstein-Barr virus is really associated with these reactions. So were there any coincident infections that could be possibly changing the differential here? And then just really understanding all of their symptoms, what their exam would have looked like if you have access to it. Labs, if available, including a tryptase or eosinophil level, any pathology photos, and looking through the medical record for maybe emergency room notes or primary care notes. And then a lot of people won't know a lot of details, but generally people do know whether they were seen in the emergency room or in their doctor's office, or certainly if they were hospitalized. And patients will also know generally how they were treated. So if they got, a shot, They might not be able to tell you it was epinephrine, but at least you'll get a sense of sort of they felt that they were, an IV medication was needed or even an IM medication was needed versus being treated at home with maybe some over-the-counter antihistamines. I always like to ask about exposures because patients will sometimes come in for a penicillin allergy evaluation and then say that they got amoxicillin at the dentist last month. That my biggest caution there is that patients fairly often say that they did get amoxicillin last month, and then I actually will call their pharmacy and ask what drug it was, and it's fairly often azithromycin, so they're just confusing the A, and actually they're incorrect. They have not had amoxicillin. So that's the caveat I would give there. So testing, what tests can we do? So the first is that we can do skin testing in order to help identify a culprit agent. This can be useful if you're in the situation where a person had, for example, perioperative anaphylaxis. There were 10 medications given simultaneously. The idea here is which of the medications was the culprit agent, trying to identify, one, usually one positive. Or the alternative is that the testing can also be useful to identify a safe drug for drug challenge in order to delabel the allergy. So the hope would be that anything that's negative on the skin testing, you would feel at that point comfortable enough to proceed on to actually administration of the drug. The thing is that skin testing is not adequate for delabeling, so we do have to proceed onto a drug challenge in order to completely delabel a drug allergy. So the prick and the intradermal skin testing is really useful for suspected IgE-mediated drug reactions. This is somewhat confusing because there certainly are cases in which the history does not sound concerning for a suspected IgE-mediated drug reaction, but nonetheless, we offer prick and intradermal skin testing to the patient. And that is often because of a risk-benefit assessment that the physician is doing or maybe the patient is doing. For example, I do prick and intradermal skin testing for all of my patients with underlying active heart disease or pulmonary disease because I think that a reaction could be more catastrophic for them. I also will, if a patient really requests skin testing, I will do it. And then the other thing would be if the history is vague. So I actually saw someone recently who he said he had hives in reaction to both Bactrim and penicillin. And, people say hives so frequently that you kind of get a little bit, your alarm bells aren't fully going off. But he was someone that I spoke to him. He was really clear that it was definitely hives. And he gave a very good description of what the hives looked like. And it was very immediate after taking the penicillin. And he was actually able to differentiate versus the Bactrim rash, which had been more and more biliform once we discussed it. And it had been more delayed. And so we actually were like, we really should do skin testing for the penicillin. And interestingly, it was positive. And obviously the downside with skin testing is there is a false positive rate. So there is a chance that that was a false positive. And indeed, he would have tolerated an oral administration. But on the other hand, he was actually undergoing transplant. He was a sick person in the hospital. I felt like it was reasonable to do skin testing in his case and, possibly avoid a drug reaction to penicillin for him. On the other hand, we were able to administer the Bactrim and delabel that allergy without a reaction. So he does still have options for his upcoming transplant. We also do have patch and delayed intradermal skin testing available. I would say, obviously these are best suited for delayed reactions. We'll discuss more in a few slides what the details are, but this is still not everywhere is offering this, and still lots of data to come about the efficacy and the utility of patch and delayed ID skin testing. There really are no commercially available drug-specific lab tests to aid in the diagnosis of drug allergy, except for the HLA B5701 for abacavir. And so although I have seen patients who've had penicillin serum testing, I put basically no emphasis on that test at all. So moving on, this is what skin testing looks like. So patients will come in and they will have the percutaneous skin testing is placed first with penicillin, and then like usually with pre-pen. We also have added amoxicillin to our testing as well. And then the second component is intradermal skin testing, in which a small concentration, a small dilute volume is placed right underneath the skin to finalize the skin testing. It is only validated for penicillin allergy, and we do have established non-irritating concentrations for many other drugs that's available, but the question is the validity. So what is the true positive rate? What is the false positive rate, etc.? So that is why skin testing alone is not adequate to rule out drug allergy and must be followed by a drug challenge, keeping in mind that patients must be off of certain medications which can interfere with skin testing. We do have immediately available results, which is really reassuring for patients. And as I said, you have to do the drug challenge. So how does a drug challenge work? So the first thing that I'll say is that the verbiage regarding the concept of a drug challenge can actually be sort of confusing. So this is what we call a drug challenge or a test dose or a drug provocation test. These are all actually the same thing, just different words. And the idea is that we're actually trying to administer the drug to determine the patient's tolerance. So we do not want to give numerous small doses, because then we could accidentally desensitize. That's where you actually induce tolerance to a medication. The idea here is, does this patient actually tolerate the drug and not have an allergic reaction to it? When you do a drug challenge and there's no skin testing first, that is called a direct challenge. So when you're reading the literature, you'll hear debates about doing skin testing and then, always followed by drug challenge versus direct challenge. And the question there is, do we have to do skin testing first for certain patients? The idea is that for direct challenges, this is appropriate for certain low-risk patients who, based on clinical history, are unlikely to be allergic. And then the other scenario is, after you've done the negative skin testing, you've done your risk-benefit assessment, you now have negative skin testing, you feel that it's appropriate to give this patient a drug challenge. These drug challenges are done under medical surveillance, and we would never do them in the situation of a scar. So no Stevens-Johnson's patients, DRESS patients, exfoliative dermatitis patients, AJET patients do not get drug challenges if you think that they had those diagnoses. If the patient passes the drug challenge without an adverse reaction, that shows you that there's no immediate or IgE-mediated drug allergy. However, it does not rule out the possibility of a delayed benign rash, because that can occur days after the challenge or within the next course, okay? So the protocol for a great challenge is generally between 10 and 25% of the dose. Generally, it's 25% if it's an oral tablet, because it's too hard to cut tablets into 10% doses. But 10% can be given if it's something like a capsule or a liquid or an IV that can be measured out to that small of a quantity. And then observe for 30 minutes. If no reaction, administer the remainder of the dose, and then observe for either 30 or 60 minutes, depending on kind of your level of concern. A question a lot of people ask is this whole caveat here with it does not rule out the possibility of a delayed benign rash. So how can you rule out the possibility of a delayed benign rash? Well, one idea you could say is to do give patients like 5 or 6 days worth of antibiotics. We don't do that in the United States. The reason is because of the risk benefit of inducing, tolerance and multiple drug resistant concerns for infections. So we don't give multiple courses of antibiotics. The Europeans kind of talk about this more than we do in the United States. And the other thing is that, at the end of the day, what I say to my patients is that we actually all have a risk of developing these delayed benign rashes. And so even if I gave you like 3 or 4 days of antibiotics and you didn't react, it still doesn't completely rule out the possibility of a delayed benign rash. So one way I like to say to patients is that after you tolerate a test dose, you can kind of consider yourself at the same risk as the general population for having a delayed benign rash. And it's less likely that we can never take that completely off the table, but at least we can say you're not going to have this scary IG-mediated anaphylaxis reaction. So the big question in the literature often is, should we be doing direct challenges versus skin test followed by a challenge? And really the emphasis is on risk stratification of the patient based on their history. Again, skin testing is of value for patients with drug-induced anaphylaxis or a recent reaction suspected to be IgE-mediated, and these patients have a skin test followed by a diagnostic drug challenge. Direct drug challenge is offered for low-risk patients with benign, non-anaphylactic reactions. And again, as I mentioned earlier, serum sickness-like reactions are no longer a strict contraindication to challenges and can be considered, especially if it's a remote reaction, an important drug for the patient. And also considering that serum sickness-like reactions can be infectious in cause. And so there is always a differential diagnosis of, was this even a drug-related reaction in the first place? So always keeping in mind the role for shared decision-making and diagnostic testing, whether it's a history of serum sickness-like reaction, IgE-mediated, or more of a benign maculopapular rash, taking into consideration what the patient prefers. And so as I slightly mentioned earlier, when we have a history of a patient who did have an immediate reaction and we need to induce drug tolerance, we can do what we call a desensitization. We do these when the evaluation is consistent with a hypersensitivity reaction. This can be based on a history of a concerning IgE-mediated reaction, positive skin testing, positive challenge, or the other situation is concerning enough history, especially in a sick patient. So the same history in a person who is ambulatory, you might just challenge them. But for an intubated patient in the ICU, you may say the risk benefit is such that I do prefer to do a desensitization. There's lots of clinical history that needs to be taken into account. We do desensitization when there is no acceptable treatment alternative, because desensitization do come with risks of anaphylaxis. And so it should not be done if there is an equally acceptable treatment alternative. And it must be performed under the supervision of a trained allergist and staff that can manage and recognize anaphylaxis. The way that it's done, as hopefully the audience knows, is by introducing dilute concentrations of the drug slowly over time and increasing the concentration as seen here in this chart. So we can see that the exposure is meant to be stepwise but continuous, and the number of dilutions and steps is chosen based on the patient history and their comorbidities. So more steps, more and slower infusions for sicker patients with higher risk of allergy. This induces a state of temporary tolerance. And so this is super important to emphasize to your patients, is that once they stop taking the antibiotic or the drug, they actually are considered allergic still and / again. And so they would have to undergo the desensitization again if they were to stop taking the drug. And so this is an example of a 3-bag IV desensitization. Bag 1 would be, for example, a 1 to 100 dilution. Then we would do a 1 to 10 dilution, and then we would do a 1 to 1 dilution, increasing the dose and the rate, and it ultimately giving the patient the same dose that they would have gotten had they not been allergic at all. So I promised I would spend a few minutes on delayed drug testing. And so there's 2 options available: delayed intradermal testing and patch testing. Delayed intradermal testing means that an ID test is placed generally in the upper arm, and it is read at generally 48 hours after placement. Patch testing is where the patient would come in, and similar to how we do with for example, the North American panel or the True test for personal care products, you can make dilute concentrations of drugs and mix them and place them in patches and apply them to patients' skin. So we really suggest doing this in this clinical scenario of delayed drug hypersensitivity reactions, where the pretest probability is high and the implicated agent is uncertain. So DRESS is a good example of a good diagnosis to do patch testing or intradermal testing for. And it's really for these well phenotype type 4 hypersensitivity reactions. And it can be useful as an adjunct to really kind of support your differential diagnosis. It really is, again, sort of in its infancy. We have no FDA-approved reagents for testing. The methods are not standardized, and which concentrations people should be using is also not standardized. And we really don't know the sensitivity, specificity, positive and negative predictive values for these various medications. So I really do suggest, using this judiciously. The patients who can really benefit from it are patients for whom they have like 6 implicated drugs in a case of DRESS. And if you did the patch testing with the delayed intradermal testing, you would be able to hopefully get a positive and be able to say this is more likely to be the culprit as opposed to the 5 negatives that we got. Less useful for someone where the cause is really clear. For those patients, I wouldn't necessarily put them through the risk benefit of doing the patch testing. And this is a useful table thinking through when is it helpful to do patch and ID testing. And I really want to emphasize that we do not do ID testing for Stevens-Johnson's TDN history. And then as it sort of makes sense, you really can't do it for organ injury or vasculitis. Fixed drug eruption, the data is for doing it intralesionally. I have to admit that I have yet to do a fixed drug eruption patch test. The reason is because if you've ever seen a fixed drug eruption, you know that they generally occur on the hands, feet, face, and genitals, all places that no one would want patch testing performed. So after you have a scar, the timing for the patch testing is really important. It should be greater than 6 weeks after the reaction, and also greater than 4 weeks after discontinuation of systemic steroids. And it really does, there's data that it's best to do it within 6 months of the diagnosis. All of those different timing caveats do make it tough to find the right time to do this testing. Generally speaking, the drug concentrations for the testing is about 1 to 10% for a powder drug and 10 to 30% for like an actual administration of the drug. A negative test does not exclude causality, but a positive test can, again, be helpful. And the sensitivity really depends on the clinical scenario, the drug itself, whether the drug concentration that was applied was correct, and then again, the phenotype of the clinical scenario. So, you can see here, for example, allopurinol really does not have any clinical utility. So again, it's sort of, we're in our infancy of understanding these tests and their utility. You can see just like huge ranges for the sensitivity of patch testing, whether this is really the right test to be doing. I can't wait to learn more about this as more data is published in the next couple of years. I know we're definitely collecting data on this in our clinic. But here's a patient who, the placement looks the same as it does for your True test. And then here's a patient who kind of usefully reacted to amoxicillin and ampicillin, but not cephalexin. And so maybe that's really helpful for them that they could more likely tolerate the cephalosporins going forward, and they should be avoiding the penicillins. So I want to spend some time on beta-lactam allergy because this is obviously so common and also really our bread and butter as allergists. So to summarize what we should be doing for penicillin allergy, we really use risk stratification based on the reaction phenotype and shared decision-making to approach our patients. A patient who had recent IgE-mediated reaction or anaphylaxis should get skin testing, and if it's positive, they need a desensitization, and if it's negative, the drug challenge is appropriate. For adults who had a reaction greater than 5 years ago, and it sounds rather benign, you would go ahead and give them the direct challenge, which, reminder, the term direct means no skin testing first. In kids, the timing is less important, so you don't need to wait the 5 years. You can go ahead and give them the direct amoxicillin challenge. And then if the patient says, you know, I'm avoiding penicillin because my mom was allergic to penicillin, no testing is needed. You can actually just delete that allergy. That's not how penicillin allergy works. And so you can go ahead and delabel it. I mean, I didn't include it on this table, but obviously a history of Stevens-Johnson's would also be no testing, keep the allergy label, strict contraindication. So what is the evidence for a direct challenge? Again, reminder, meaning no skin testing. So we have a couple of nicely done trials that really are the basis of this evaluation. We had a randomized control trial in which 159 patients who were greater than 5 years old were randomized to skin testing or a two-step direct challenge. And the skin test was negative in 70 of 80 patients. And then all the 70 patients who were skin test negative went on to tolerate amoxicillin. In the patients who, again, they were randomized, they had direct challenge negative in 96.5%. So overall, we have a better likelihood of actually tolerating amoxicillin. And in fact, there was maybe some of these 10 patients who had the penicillin skin test being positive. Perhaps that was, in fact, a false positive. And so it actually led to them retaining their penicillin allergy label potentially incorrectly. And then they also, I didn't present it in this little summary, but they also showed it took less time to do the direct challenge, cost less money. And so those are also some advantages. We also have the PALIS randomized clinical trial in which the group looked at using the PenFast score, which I'm going to have on the next slide. And it showed that doing penicillin skin testing followed by an oral challenge was just as safe and effective as using the PenFast score. And so the argument here is that if you use the PenFast score correctly, then you can identify patients who would be good candidates for the direct challenge. So this is the PenFast score. It's an acronym. So PEN is penicillin allergies reported by the patient. F is for 5 years or less since the reaction, and if it was recent, they get 2 points. A is anaphylaxis or angioedema or a severe cutaneous adverse reaction, and that would give you 2 points. And then treatment required for a reaction or unknown gives you 1 point, okay? And then how many points you have overall, you should not be giving the patients with moderate or high points the direct challenges. It has a negative predictive value of 96%. And I always want to include, how many times can I say this in one talk, but the history of a scar is a contraindication for a re-challenge. Even if these evaluations got you only a score of 2, this right away, if you get a score for the S, you're out. You cannot qualify for challenge. So what should we do about cephalosporins? This is an important thing to consider, is that with the practice parameters that at this point were published in 2022, if you have an unverified, so that means not confirmed, non-anaphylactic penicillin allergy, a cephalosporin can be administered without testing or additional precautions. But for patients with a history of anaphylaxis to a penicillin, patients can get a dissimilar R1 side chain cephalosporin without testing, or you can go ahead and do penicillin skin testing. If at that point it's positive, you can do the desensitization for the indicated cephalosporin with the structural similarity. And the thing to remember is that cefazolin is structurally dissimilar to all other cephalosporins and penicillins, and thus can be administered without testing or additional precautions, regardless of the penicillin allergy label. And this is a really important practice change because cefazolin is often the drug that's given preoperatively to minimize the risk of surgical site infections. And so super importantly, our patients with penicillin allergy labels should be getting cefazolin preoperatively, even without having a penicillin allergy delabeled. So this is kind of the way of thinking through what I just said in a different method of thinking through it. So as opposed to written, this is the table. So if you have a structurally similar cephalosporin being given and there's an anaphylactic history, then yes, you need to do penicillin skin testing. And if it's positive, you're doing maybe a descent, or if you really don't trust your skin testing, you could do a drug challenge. But if you're over here and the patient has, it's either a structurally dissimilar cephalosporin that's being given, or it is a structurally similar cephalosporin being given, but the history is non-anaphylactic for the penicillin allergy, then you can go ahead and give the cephalosporin. And you could do a drug challenge, but you actually truly can just give it if you want to, based on the guidelines. And again, if the skin testing was negative, then you actually, again, can go ahead and give your cephalosporin. So I know the table is a little bit confusing, but actually what it says is sort of what we kind of would think it should say. And I know this is the most confusing table, truly I understand, because Dr. Blumenthal and I work closely together on updating it, and it does make your eyes cross when you look at it for too long. But we go through and we update the side chains as more data is produced every few years, and I just throw it up to kind of demonstrate what I mean when people talk about identical or similar structurally R1 side chains, is that the R1 side chain is what determines the allergenicity of a specific cephalosporin. So what we can see here is that if you wanted to give cefadroxil and the patient had a history of reacting to, as I said, like amoxicillin, then you would have to avoid cefadroxil or do skin testing to the penicillin, and if positive, desensitize to cefadroxil because it has the same side chain as amoxicillin. But if you are looking over here at, ceftazidime does not have the same side chain as the penicillins, so this can be given normally in a patient with a listed penicillin allergy. No further testing is needed. The other thing to really emphasize is that cefazolin has no structural cross-reactivity with any of its cephalosporin or penicillin friends, and so it can be given without further testing, especially for our preoperative patients who need it and can minimize surgical site infections. So at the beginning of the talk, there was a little discussion of how I was involved in the writing of this useful drug allergy resource, and I just include it in the end of the talk because it really is a very useful piece of a reference for allergists and non-allergists alike. It goes through and there's a guide for skin testing, challenges, and desensitizations for almost every category of drug. We worked super hard on this. At this point, it did come out quite a while ago. It was 2020 it was published. And so every year I'm also part of a group of us who work to put an online annual update by the Quad AI Drug Allergy Committee. And we post this without like before the paywall on the Jackie in Practice page. So if you go to the Jackie in Practice webpage and scroll down to the bottom of the page, there's a link there that says drug allergy. And if you click there, it will lead you to a page that actually has a link to this, but also this page that I have a screenshot of right here. And then we actually go through and try to update it every single year with the most relevant literature that's come out in the past year, so that it's sort of meant to be a compendium to this document to make sure that we're not missing anything. So, in case there's been any new information that's come out since this was published. So that hopefully that's a useful resource for people who are trying to just be up to date on the latest information about drug allergy. So my take-home points from today is that hypersensitivity reactions comprise a small subset of adverse drug reactions. Careful drug allergy history complemented by physical exam and laboratory data when available allows risk stratification and facilitates effective management of drug reactions. Patients with histories of distant and benign cutaneous reactions are low risk and can be delabeled via direct drug challenge without preceding skin test. Skin testing, challenges, and desensitization can be performed by an allergist to aid in the diagnosis and treatment of moderate to high risk patients. and we have specific data and recommendations for beta-lactam allergy and risk stratification helps guide our management. So I wanted to say thank you to this team of people that I work closely with, and thank you for some of the slides. And I have a question that I'd like to kind of end on. The question is, a 45-year-old woman comes to your clinic to discuss her drug allergies. She has 40 listed allergies from a variety of drug classes. The listed reaction is hives or rashes for the majority of medications. When obtaining her history, which of the following should be the focus? A, whether she vomited during her reactions. B, the location on her body of her rashes or hives. C, a history of hives unrelated to medications. And D, whether she also has angioedema. So the answer that I was thinking about here is C, a history of hives unrelated to medications. And so I end on a point that I actually did not make throughout the entire talk, which is that this is actually not a drug allergy patient. This is a patient with chronic spontaneous urticaria, and she is sort of inappropriately attributing her hive reactions to medications that she gets on. We know that chronic spontaneous urticaria is exacerbated by illnesses and certainly medications as well. And so I would wonder if this patient actually is not a multiple hypersensitivity drug reaction patient, but in fact has undiagnosed, unrecognized chronic spontaneous urticaria, and that getting her chronic spontaneous urticaria under control is the first line of business, and then going through her drug allergy list and delabeling her would be the correct approach. So I will end there.
Okay. Thank you, Dr. Wolfson. That was fantastic. We'll open up questions from the audience.
I have one quick question. So let's say you do the delayed patch testing for amoxicillin. It comes back positive. As far as cross-reactivity and R1 side chains, it's kind of the same recommendations then in that case?
No, so the R1 side chains are really only useful for the Ig-mediated reactions, and so the problem is, like, the allergen in that case could be the beta-lactam ring. So the R1 side chain is what mediates allergic reactions when it's IgE-mediated, but what is the antigen for the T cell in the case of Stevens-Johnson? It could be the beta-lactam ring. Like, we don't know, and it could be different between different patients. And so, you know, technically the answer to your question is that that person, if they had Stevens-Johnson's and that was the reason why you had done the patch testing in the first place, you would avoid all beta-lactams. If they had, you know, a maculopapular rash and you did it for that reason, I certainly would not avoid all beta-lactams, but so the clinical history makes the diagnosis, but it is a class effect when it comes to those really severe scars.
Thank you.
Other questions? I'll throw out one. The basophil activation test. Are we getting anywhere other than research on those?
I don't think, not that I have heard. Are you aware of anything? I really have not. We have it still. I mean, I know my research, my bench lab colleagues are definitely doing basophil activation tests, but I really don't have a way of getting my hands on it at all. And I have patients ask for it fairly often, actually, but I've actually never done one for a clinical case.
Okay. Yeah. From a research perspective, it's really interesting, but from a clinical utility, I'm not aware of any great data on that end.
Yeah.
So, okay. All right. Well, unless we have any other questions, we'll go ahead and make this a wrap for today. Thank you, Dr. Wolfson, for being here, and appreciate your expertise. And again, we'll get this edited and up to YouTube in the near future here.
Okay. Thank you so much for having me. Take care.
Okay. Thank you. We appreciate you. All right. Thanks, everybody.